Hi there, medical assistants. Welcome to your next lecture covering injections. Today we'll be talking about subcutaneous injections. The material that we're covering today in lecture is going to talk about the purpose and function of the subq injection, how and when we use it. The reader that you have in your modules is going to get a little bit more into detail about how we're actually going to perform it. And of course, we'll be talking about that in class. So be ready for lab coming next Monday. We're going to be starting with these types of injections, and we'll start practicing and learning right away. So study up your material and be ready to go. So subcutaneous injections, noted as subq or sometimes SQ, are given into the fatty layer under the skin. And you'll recall that is called the subcutaneous layer. Generally speaking, they're used for smaller doses of non-irritating drugs. As we discussed in last lecture, it's often a half mil. The volume that we inject when we use subq has to be less than 2 milliliters. And the reason for that is absorption. So in the fatty tissue, as it says here, medication is absorbed more slowly than when administered into muscle tissue. And there's one exception to that rule, and I'll just tell you right now, it's insulin. Insulin will actually absorb faster in subq tissue. But generally speaking, when you go into the subq layer, it's a more slow type of absorption. And that's attributed to the fact that there's not much vasculature in the fatty tissue. Another way to say that is there's little blood flow. So when we talk about vasculature, we're talking about the network of blood vessels within tissue. Kind of an overview. So common injections for subq route, and subq is a route, by the way. So some of the common injections for route, some of the common injections used for this route are insulin, heparin, which is a blood thinner, allergy shots, which is kind of what they are. You're all familiar with vaccines, and epinephrine, and some infertility drugs. Although most of those are IM, some are given through the subq route. The actual literal route of the subq injection, once again, is the fatty tissue below the skin. I prefer just to say the subcutaneous tissue. We learn terminology so that we don't have to say long sentences. And so if we say the subq tissue, we're already saying fatty tissue below the skin, right? So efficient to say subcutaneous tissue. The syringe types will be similar to what I said before. So there are such things as 1 mil syringes. We don't see them often. We usually see them in 3s or 5s. So anywhere between a 1 and a 3 mil syringe will work. A 5 would work also, although it'd be quite big to do in immunization or a subq. You could use it. And of course the insulin syringe, which is very short, has a very short needle of a 1/2 inch and is very thin. Gauges, generally speaking, the most common is the 25 gauge, but somewhere in that 23 to 25 range for most vaccines or most subq injections. And that 1/2 inch needle that you see on the insulin syringe is usually a 29 to 31. So those are usually very thin. The length, anywhere between a 1/2 and 5/8 inch. 1/2 inch more for infants, 5/8 more for adults. And of course, the idea behind this is we use a shorter needle so that it stays within the subcutaneous tissue and doesn't reach the muscle. So we don't want to put subq medication into a muscle. And the reason, once again, is it's all about the absorption. When you absorb into subq tissue, it's at a different absorption rate than you will get with an IM type of injection when you're going into muscular tissue. So when we talk about the angle of insertion for a subq injection, it's generally speaking 45 degrees, and that's for a 5/8 inch needle. 90 degrees for a 1/2 inch needle. So that's, once again, they're talking about insulin, heparin. Once again, a 1/2 inch needle is most likely going to be used on a newborn or on an infant. Generally, what I was always taught is they all go in at 45 degrees. Although I do see sometimes people will administer them at 90 degrees. And it just really depends on the needle length. The way I was taught, where I always worked, they only wanted us to use 5/8. And so we always use the 45 degree angle. So sometimes this is specific to the facility that you're working at. Just be familiar with the idea that you're going to be using a 45 degree angle if it's a 5/8 inch needle. And that's generally what we'll be working on in class when we practice. So as I said earlier, our dosage range is about a 1/2 mil to a mil. And varicella and some of those vaccines go up to 1 mil or 1 cc. Most, as I said previously, are a half mil or 0.5 ml. You never give more than 2 ml, and make sure you always check that medication 3 times. Look at it before you draw it up, right as you're drawing it up, and before you put it back on the shelf or in the refrigerator from where you got it. Because you want to make sure it's the right medication that you're taking into the room to administer to that patient. We'll talk a little bit about the medications now. As I had said before, insulin's it may be something that you're going to administer depending on the facility you work at or the physician you work for. And you may never administer insulin. So there's a wide range of possibilities there. So be prepared for it and understand what the equipment looks like. Don't expect to be doing it on a daily basis because chances are you probably won't be. But it's always good to know. Insulin's measured in units. So these aren't mLs. They are not cc's. They are units. It's a subdivision of a bigger unit. Insulin should always be stored in the refrigerator. Always use an insulin syringe. The reason for that is we have to be very specific with our doses with insulin. And the units are the way that we measure insulin, and we never deviate from that. So we would never substitute and say, well, we're going to do a half mil of insulin as opposed to 3 units. First of all, there would be a big difference between those volumes. And second of all, it would be really hard to guess in a standard syringe that's marked of increments of milliliters or cc's. It would be very, very hard to gauge how many units you actually had in there. Often there are 2 types of insulins that are mixed. So you may be in a situation where you'll have to mix a fast-acting and a long-acting insulin together. Although in modern diabetes therapy, there are so many combo variations on that are already manufactured that way and they're already mixed. So it doesn't always have to be something that you'll do on site, but it might be. So be prepared in case it does come your way. Abdomen is the most recommended site. It absorbs the quickest there. And when it comes to really any type of injection, but especially on these subq injections, do not rub or massage the site after the injection. You could affect the absorption rate. You could cause increased irritation. You might even cause a welt or another type of reaction there. So if you can't control what a patient does, you can ask them to not rub it. I have seen at times that people will do that. They'll rub the injection site right afterwards kind of vigorously and kind of in an aggressive way. I would recommend not doing that. It's really not considered to be a good idea for the reasons stated, of course. Heparin's a type of blood thinner. Once again, the abdomen. And you want to stay away, at least 2 inches away from the umbilicus when you're doing blood thinners, this type of injection. It has to be administered very slowly. And the needle stays in place for 10 seconds after the injection and then withdraw it. And this is because it's a blood thinning medication. So we want to take our time with this. Once again, don't rub or massage the site after the injection. I said it just a moment ago. I'll say it again. Insulin and blood thinners like heparin are things you're not likely to administer, but you might, depending on the physician. So be aware that there are certain rules that apply to those types of medications when it comes to subq injection routes. And of course, vaccines. Now, this is something you're very likely to be doing as a medical assistant if you work in the clinical realm. Front office, back office. So back office, clinical. Clinical is what I was my entire career and still am as an MA. And vaccines are what we do. So we have all types of vaccines that apply to diseases that are still common in the United States. Varicella, pertussis, hepatitis B, influenza, pneumococcus. These are some of the ones that we still see. We have lower immunization rates in some areas of the country. And when we see that happening, we also see the cases start to rise. And this is measles, mumps, Haemophilus B. We see it with varicella. One of the things you have to remember about some of these diseases, and I'll just focus on chickenpox because it's one of those that people try to, or not try, but will promote active immunity by exposing their child. They have chickenpox parties and it's true, it will build immunity if they catch the disease. The thing you have to remember about many of these diseases is that we don't see the effects of them because we immunize against them, so we really don't understand how dangerous they could potentially be. When it comes to something like chickenpox is a respiratory disease. It can be a very deadly disease. In fact, it could be as deadly as COVID. It doesn't spread as quickly, or it doesn't spread as quickly in our modern society because we immunize against it. But the idea that, oh, we're just going to get a skin rash and a fever and it's over, that's not at all true. It's a respiratory disease. It can cause scarring in the lungs and other bad side effects that you wouldn't want to see in the long run. So when we talk about those immunization rates going down in some places because of sort of an anti-vaccine standpoint, people do have the choice to do with their bodies what they choose. However, it does affect our disease state. And so we always want to encourage safe vaccines. Getting back to the slide here, we have international travel. So just a plane ride away, you can run into polio, rubella, diphtheria, measles, mumps. We don't think of those as active diseases in the United States, once again, because we immunize against them. But I can absolutely assure you, I've been places in the world where these are very active diseases that are going on, and they are still out there. And if we start lowering our immunization rates in the United States, we'll start seeing more of these types of diseases. Not to mention the ones that we're already immunizing against will become stronger. So we really want to avoid that. We do want to promote safe vaccines. One more vaccine that we use, DT, for tetanus and diphtheria. Tetanus is something that's within the environment. It's in soil. It's around us. So a puncture wound can introduce it, and then it can cause some really sort of very severe and intense muscle cramping throughout the entire body. The type that is, without getting into too much detail, it's a disease we do not want to promote and we do not want to be exposed to, so we really need that tetanus shot. It will cause the muscles to seize up in a way that's extremely uncomfortable and could have a really poor outcome for our patient. So we want to immunize against that. Fortunately, we bond a lot of these together, so instead of getting an individual shot for each, we get combination shots. All right, I'm going to pause it there. I'll be back in just a moment. We've just got to our 12-minute mark, and I have only 15 minutes in these segments. So I'll be back with another 12 to 15 minutes in just a moment about subq injections.